Well, a warm welcome to today's talk, and as you can see, it's pretty dark outside. It's rained here for days. Autumn has well and truly arrived. Now, of course, we did a video a couple of days ago on the new antiviral from Merck called Molnupiravir that's seeking FDA and international approval at the moment, and I had about 6,000 questions on relating modern this new antiviral drug to potential older antiviral drugs. So that's what this is about. So we're going to compare Molnupiravir with Ivermectin. Now, I'm aware that this issue is sensitive, shall we say. So everything I say is going to be based on evidence, and I'm going to show you the evidence. And where the evidence is unclear, I'm going to be upfront about that and tell you about that. Now, we're going to start off by looking at this paper here. So this recently published paper. Now, this is published from Austin Publishing, which is a peer-reviewed publishing group. Drugs shown to inhibit SARS coronavirus 2 in COVID-19 disease. Comparative, basic and clinical pharmacology of Molnupiravir and Ivermectin. So this is a brief paper, but covers quite a lot of key points and does quite a few interesting comparisons. Now, because we're very keen to look at validity here, I did check up the main author, and he is a professor of medicine in Texas, with a specialist expertise, adjunct professor of medicine at Balliol College of Medicine, with particular expertise, of course, as you would expect, in pharmacology. So that's the author of this paper as we try and check what we're saying as we go through. Right, there's still many nations where vaccines are not widely available, accepted fact. Vaccine rollout is patchy around the world at best. There's a gradual shift to focus to antiviral drugs. Now, if there was good quality antiviral drugs, then countries that are still waiting to be vaccinated, the impact could be much less because they would have antiviral drugs potentially to prevent the transmission of the disease and to treat it should it occur. Because the analogy I've used many times, if you've watched this channel, is bubonic plague, which killed people in the Black Death it killed huge percentages of the population in the past. But now we just treat it with antibiotics. We don't vaccinate against it. We just treat it when it arises. So we need this as an adjunct to vaccination is the thinking of this paper. So adjunctive chemoprophylaxis. Now, chemo means it's a chemical, a drug. Prophylaxis means to prevent. Adjunctive means it's as well as the vaccine. So we don't want to get into this argument. Do we want antivirals or do we want the vaccines? I want both. I'm pro-vaccine, I'm also pro-antiviral. We don't want divisions into different camps. That is not helpful. We want to examine what the truth is. So the active treatment of the SARS coronavirus 2 infections. So for adjunctive preventative treatment and for active treatment as well, both would be brilliant. We want to stop people getting it, and we certainly want to treat them when they do get sick if we can. And also for post-vaccine breakthrough cases, which, okay, there are some issues with that at the moment, so we'll accept that. Two ways to get new drugs: develop novel antivirals, so new ones, or repurpose existing drugs. Now, there's a lot of repurposing of drugs gone on in the history of medicine. If we take aspirin, for example, I mean, aspirin comes from willow bark, and it was first used to treat fevers. But then people realised it was a painkiller, it was an analgesic, and then people realised it made your platelets less sticky. So we give it as an anti-platelet, blood thinning drug as well. And there's lots of examples of this where one drug was developed for one thing and it finds out to be useful for another thing. So repurposing wouldn't be at all surprising, as well worth looking at. Of course, an example from this pandemic that's unambiguous is steroids. They've been repurposed. So steroid drugs that have been using all my career, so at least for the last 40 odd years. And then we repurposed it to treat the inflammatory complications of COVID-19. So that's not surprising. So Ivermectin is the most studied repurposed drug according to this paper. Just quoting what the paper says. In randomized clinical trials, retrospective studies and meta-analyses, this paper is claiming. And do read the whole paper for yourself. Some of the biochemistry is a bit technical, but you should kind of get the gist of it. It's not totally inaccessible, although it is a scientific paper. Molnupiravir and Ivermectin, anti-SARS coronavirus 2 mechanisms. Pharmacokinetics is the way that the body interacts with the drug. And pharmacodynamics is the way that the drug works on the body to have an effect, whether that effect is good or that effect is bad. So Molnupiravir, broad-spectrum antiviral agent against SARS coronavirus 2. And I believe it was first developed to treat influenza, so it's got action against seasonal seasonal or pandemic influenza, and also MERS coronavirus. So fairly broad spectrum, really. And the data we looked at released from Merck does show that Molnupiravir is active against all of the variants so far that the study was able to incorporate. Anyway, all of the variants of COVID-19. So ivermectin is an FDA-approved WHO essential drug as a broad-spectrum antiparasitic and antibiotic, he's saying. And of course, it won the Nobel Prize. The two discoverers won the Nobel Prize co-won the Nobel Prize in 2015, as ivermectin has revolutionised the human treatment of parasitic disease around the world. Direct quote from the paper, and which has demonstrated broad-spectrum antiviral activity against RNA viruses, including HIV, Zika, MERS, coronavirus. So that is the quote from that paper. Check it out for yourself. The FDA-approved drug ivermectin inhibits the replication of SARS coronavirus 2 in vitro. Now, this means in experimental circumstances, and this again is not ambiguous. This goes way back to what paper was this? This goes way back to this paper here. One of the early papers from 2020 from Australia. The FDA-approved drug ivermectin inhibits replication of SARS coronavirus 2 in vitro. Not in vivo, this is looking at in vitro. So that is there, and I think this is pretty well, I think we can say that's pretty well accepted science now. No one seems to debate that particular point anymore. 5,000-fold inhibition of SARS coronavirus 2 got rid of 99.98% of viral particles in the first 48 hours. Remember, that is the ivermectin in vitro. Now, the inhibitory concentration, so-called IC50 of Molnupiravir, it shows to be more potent because you need less Molnupiravir in the tissues, according to this data here, to get the therapeutic effect. So that would be a dosing thing, and that would be the timing of the interventions. But it's looking like the Molnupiravir is working on lower tissue concentrations, but it's a bit more complicated, as we'll see. Both Molnupiravir and ivermectin are well absorbed orally, so you take them by mouth. This is the big example, but the big selling point of the new Molnupiravir is you don't need to give it via an intravenous infusion like you do the monoclonal antibodies. Tmax is the time it takes to get to maximum plasma concentrations. For Molnupiravir, it takes about 1 to 2 hours to get to maximum concentration. With ivermectin, it takes a bit longer, 4 to 6 hours. You need to give 2 doses of Molnupiravir a day because the half-life, the time taken to excrete half of the given dose of the drug from the plasma, is 7 hours. Whereas ivermectin, it's long. Now, this paper quotes 81 to 91 hours. Now, this is surprisingly long. I had thought it was around 17 hours, but I'm just quoting what this paper says. And being lipophilic has a large volume of distribution. In other words, it dissolves in fatty tissues, and of course the cell membranes of the body are fatty tissues, so it's able to diffuse into a very wide number of cells, the ivermectin is. Ivermectin has the ability to accumulate in the lungs, which of course is one of the main target organ for SARS coronavirus 2. So it's not just about the half-life with ivermectin, it seems to accumulate in the tissues in the lungs. And as far as we understand from my conversation with vets, it stays there for a long period of time. So it can have a long-acting effect locally in the lungs. So you could end up with higher concentrations in the lungs than other places, which of course, in terms of treating severe acute respiratory distress syndrome, is exactly where you want it. So the normal sort of kinetics of drugs is a little changed. It's not just half-life, it's where the drug accumulates in the tissues the drug accumulates in that we would need to take account of. The anti-SARS coronavirus 2 actions, both of Molnupiravir and ivermectin, are dose and concentration dependent, as we've said. Molnupiravir is an active. It's what you call a prodrug. The Molnupiravir is given. It's converted, I believe, in the liver into the active substance. Now, this isn't uncommon in pharmacology. So, for example, if we take codeine, for example. The reason that codeine is a painkiller is the codeine goes to the liver, and the liver converts it to morphine. So it's actually the morphine that's having the pain-killing effect. So again, this is not surprising. Drugs and drug metabolites are well recognised in pharmacology. So the active metabolite, NHC5 triphosphate, acts as a competitive alternative substrate for viral RNA. Now, I'll tell you what I understand by this. So the RNA is made of bases, and this acts so it's made of these 4 bases to make the new RNA molecule, which of course is what the virus runs on. It runs on RNA, whereas we run on DNA. And this is like a substrate that gets into the new RNA molecule and basically sabotages the molecule. Now, that's the way I understand it at the moment. If my understanding improves, I will certainly get you on that. But it's like a competitive substrate. So instead of having the proper substrate that the virus would like, you get this Molnupiravir substrate, and that kills that goes on to cause mutations in the virus and makes the new viral particles non-viable. So it stops replication of the virus. That's my understanding at the moment. As I say, if it's wrong or it needs corrected or purified, we'll get back on that. But that's my understanding just now. Causes viral mutagenesis, so it causes mutation in the virus, mutations which lead to viral error, catastrophe, and extinction of replication. In other words, it can't reproduce with this dodgy stuff inside it. Now, the direct quote from this paper, there's some concern about the safety of this metabolite, which also is mutagenic to mammalian cells. Now, the Merck announcement said yesterday that wasn't a problem. This paper suggests that it needs, well, at least it needs looking into. So the idea here is if it stops the normal replication of RNA, is it going to stop the normal replication of our own DNA? So that's all I'm saying is that's a direct quote from the paper. Of course, all the data from Merck, as we understand it now, is with the FDA and the European Medicines Agency and all the regulatory authorities around the world. They've got probably about 1,000 times more information than we have, but that's all we can say from public domain data at the moment. They will have to make adjudications on that. But Merck's statement yesterday indicated that this wouldn't be a problem, but this paper indicates that it needs to be considered at least. Ivermectin works in different ways. It binds to the spike protein to stop the spike protein going into the cell. It affects the ACE2 receptor to stop the virus going into the cell as well, and it reduces the viral transcription. In other words, it stops the production of new viral RNA, according to this paper that we're analysing today. So a wide variety of actions, and also ivermectin is anti-inflammatory as well, which is why people are studying its potential efficacy against long COVID. Inhibits cytokine production. It's in the pro-inflammatory cytokines that cause the inflammation. Molnupiravir doesn't seem to be anti-inflammatory, but we await further data. So complementary pharmacokinetics and pharmacology of the drug might give rise to an additive or a synergistic effect. Now, what this is saying is these two drugs work in different ways. So if they were given together, you might get an effect of 2 from the ivermectin and an effect of 2 from the molnupiravir, giving a total action of 4. But there again, it might be synergistic. So you might get an effect of 2 from the molnupiravir, an effect of 2 from the ivermectin, but that might end up in an 8 times improvement. It could be a synergistic effect. Don't know. Work hasn't been done as far as we are aware. Certainly not published that I've seen. So could be given together basically is what this paper is suggesting could be investigated. In fact, they say this should be further investigated in an anti-SARS coronavirus 2 antiviral combination therapy is what this study is suggesting as a possible combination treatment. A combination of molnupiravir with ivermectin, maybe, we don't know. So that's a possibility. Now, what we are firmer about is the cost. Now, so far, the molnupiravir is about $700 a course. So it's, I think, as far as I know, it's BD. That's twice a day for 5 days. So that would be a total of 10 capsules, and that would equal $70 per capsule. That's the price that the US government seems to have paid so far. What the eventual price will be, Merck has said the price will be different depending on what the country can afford, which is good, of course. So that's kind of the price so far. We're looking at about $700 a course. Now, according to the World Health Organization, the cost of a packet of 100 ivermectin tablets is 3 milligram tablets is $2.96. So say we took 12 milligrams a day for 5 days, that will give a total cost of treatment of 53 cents, which is about 45 English pennies. So that is the comparative cost of the two drugs. Now, the comparative safety, of course, we don't know yet because we don't know the safety of molnupiravir, But this is from, let me show you where this is from. This is from Vigibase, which apparently picks up most of the world's prescriptions. It's a Uppsala monitoring centre combined with the WHO and all sorts of things from the place in Sweden where it first started. And it's looking at the risk and side effects of drugs. You can check it out there. And it's absolutely great because you can actually go into this and you can look up the safety profile of any drug. It really is quite an impressive, database, this. So let me just give you a couple of examples from it. Ivermectin, 3.7 billion doses have been given. 3.7 billion doses given to human beings. This is not counting animal data. That's 3.7 billion doses have been given to people. And the adverse events reported are 5,693. If we compare that with another common drug like amoxicillin, where there's been 136,000 reported adverse events, and another common drug like ibuprofen, which is the aspirin type anti-inflammatory, we call it brufen in this country, 165,000 adverse events reported. So from that we see that ivermectin's got a very low amount of adverse events reported compared to those couple of other common pharmaceuticals. And as I say, of course, we don't have this data yet for Molnupiravir because this is post-release data. How well do they work? The efficacy. Well, we know that the Molnupiravir is about 50% reduction in deaths and hospitalisations from yesterday. So we can say roughly Molnupiravir preventing 50% of hospitalisations and deaths. Those studies being done in people that had at least one risk factor for hospitalisation or death being treated early. Ivermectin, so we're saying about 50% efficacy, preventing hospitalisation and death for the Molnupiravir is kind of the figure that we're working on from yesterday's video, day before's video. Ivermectin, this paper here, this is the Tess Laurie paper. She's saying a 62% benefit from her meta-analysis with a moderate certainty evidence. Do look at this amazing ongoing meta-analysis here. Now, this is lifetime. So, for example, when there was a question over the efficacy or the validity, really, of the data from an Elgazar study, I think it was in Egypt, they simply took it out and recalculated it. So they were doing this on an ongoing basis. So they're saying that early treatment, so that would be like 0 would be there, 1 making no difference would be there. And so they're saying that this is like about, it's about 0.3, isn't it? So yes, a 66% improvement, they're saying, from early treatment. Late treatment with ivermectin, they're claiming a 40% improvement from their analyses, and prophylaxis, they suggest an 86% improvement. So 2 very positive meta-analyses there on the efficacy of ivermectin. Look at them for yourself. They are there, they are accessible. I've given you the links. Counter-argument comes from the Cochrane Library, which does a lot of peer reviews. Main results treating people in hospital with COVID-19. Now, I have mentioned this before from the Cochrane Library. I think this was largely carried out by German academics. And all I'm going to do, because I've gone on for some time now, is I'm just going to quote the plain language, the plain English summary on this, just to give us an idea of what they're saying. They're saying we don't know whether ivermectin compared to placebo or usual treatment at 28 days after treatment leads to more or fewer deaths. They're saying they don't know. Worsens or improves patient condition, assessed by need for oxygen or ventilation. They're saying they don't know. Increases or reduces unwanted events. They're saying they don't know. Prevented COVID-19. They're saying they don't know. So there's a definite don't know on that one, just from the plain language summary there, whereas the other 2 are positive. So there we go. Let's leave you to think about that for a little while. That's my best interpretation of the data as we have it now. If I've got something wrong, I will come back and correct it, but it's an ongoing situation. And we really need our leaders to be more definitive in the guidelines that they are currently giving. Thank you for watching. Let's have a quick update from Wefwafwa now on, I think the first one is Ben. We'll maybe look at an update from Ben. So let's look at Ben now. As this is the community outreach project, of course, we are following in Africa, in Uganda.
Hello guys, welcome to our channel. This is Wefwafwa Andrew and we are back to the community. I am with my friend Ben here. Now today is a special day and I'm so excited. This is because at least now we have been able to come back in time. We found Ben still has some medicine. We found that he still has some of the food, and the mother has told us that the appetite of Ben has now improved. Now I believe this is because his pain is under control. Today we brought him some more food and some medicine to keep him for about 2 weeks again. Now, today we are not only going to visit Ben, but we are also going to see Hezekiah in the same video. For those of you who have been following our videos, something like 2 months ago, we visited Hezekiah, who is a 7-year-old boy who has diabetes mellitus type 1, and we were able to teach the mother about the diabetic diet. We bought for them some food, and we also bought them a glucometer. As I talk, I have been receiving reports that the Hezekiah's condition is now good. They can be able to monitor his blood sugar, and they have now knowledge on nutrition. So today we are here. You are going to see 2 videos in one. We are going to visit Hezekiah and we are going to work on Ben as well. So I'm going to start by cleaning Benny's wounds, and then of course we have already given them the food. Then from here we shall move to see Hezekiah because they come from the same location. So guys, enjoy this video.
And now friends, here I was dressing Benny's wound after cleaning the wounds. I know some people are not comfortable with seeing the pus. That's why I didn't show when I was cleaning the pus. But the good thing is that the pain has reduced and the pus is also reducing compared to the previous days when I used to clean Benny's wound. That means the medicine is helping him very well, and at least even the appetite is there because his pain is under control and we are feeding him on a balanced diet. So I just want to thank you all who have supported Ben up to this time, and you who have supported all the work that we are doing on this channel. So guys, the surgeon looked at the x-ray of the bones and they were severely affected. So he advised that we put Ben on a balanced diet and we be doing wound dressing, and we give him some medicine. We observe him for something like 2 months, and then we go back and do the x-ray again and see if the surgery can be done to help Benny's condition. So for now, I'm just doing what they instructed me to do as we wait for that time to come. We have so far made now 1 month of dressing, putting Ben on a balanced diet, and also giving him some medicine for pain. So friends, for now, I'm doing what I was instructed to do. We have moved a period of now about 1 month out of 2. Yeah, we need to continue doing these things for about 2 months before we go back to see the surgeon. So we need more prayers, we need more support, such that we shall keep Ben in this good condition until the time we shall go back to meet the surgeon. Otherwise, thank you very much for the love. Thank you very much for the care. I don't know how I can appreciate you, but I just want to say thank you. And I really love you. Thank you for standing with us, and may God bless you.
So guys, we are now done with wound dressing. Now today we've not captured from outside because when I started working on Ben, it was drizzling outside. Hope you are able to see us clearly. We are here seated in Ben's room. Here are his beddings. So I'm now done with dressing him. We are now moving to another place where we are going to visit Hezekiah, who is a 17 years old boy suffering from diabetes mellitus type 1. I received information that he's doing well. So let's go there and find out how he is doing. Hello guys, welcome to our channel once again. We are finally at Mama Hezekiah's place. We found Hezekiah is in very good condition. Mama has kept him very well. His blood sugar is under control and he is receiving proper medication. I am so grateful to you all who supported Hezekiah during that time when we needed support. Remember, we were able to buy him a blood sugar machine, that is the glucometer, and today we just came to check on him. So we just got some little food again. But our major purpose of coming today, we just wanted to know how Hezekiah is doing and we wanted to update you guys. As you can see, Hezekiah is in good condition. Hezekiah, yes, I've asked him to wait for you guys. So this is the mother. Let me just ask her how Hezekiah is doing, and maybe you can hear from her. Hezekiah ali
Zekiyo mulayi nabi kutulanga mwenza mwandekera kyekukola Zekiyo ali mulayi kaliko ni buwanga kubosizana ta.
That's good. Hezekiah mwenye oli mulayi. Yeah, so I've interacted with Mama. She has said that Hezekiah is very okay. That since the last time we came and taught them about the diet and we brought the blood, the glucometer, Hezekiah's life has improved. So thank you guys for all the support that you gave Hezekiah, and thank you for all the support that you've given us along the way. We are doing a lot of things, but we could not have been able to do all those things alone, but because of your support we are able to move and see different people. So thank you very much. If it is your first time here, please consider subscribing, like and share this video with all.
Okie doke. Brilliant. I just find that this project just immensely moving. Fantastic. So just a couple of the pages there. Now, just on the ethical side of this, Wefwafwa does everything properly. He does work for an NGO, although this is in addition to that work. He is registered as a medical officer with the government, and he always gets permission from the local authorities to work in a particular area, and he gets permission from the local village eldership as well. And of course, all of the participants in the videos have given their permission, and they've all, well, it's not just they've given permission, they've all been delighted that someone's taking an interest in their condition. So just a couple of patients we're following from Wefwafwa. We will carry on doing so. Links to Wefwafwa's channel, links to that video, links to an opportunity to support Wefwafwa with Patreon, even if it's only for a month or two. That would be brilliant as he expands his educational and medical outreaches, which of course is about the most cost-effective way you can spend money on healthcare, really. And there we go. I can understand it's drizzling there. The weather here is terrible. It's just rained all the time. Let me just show you. It's like constant rain. If I turn those lights off, you might better see it better. It's just rain for days. But there you go. That's what you get if you live in the north of England. But anyway, that's great. Thank you for watching, and do click onto Wefwafwa's channel.